I have to be a bit more here, actually.
There's a bit of feedback.
Do you hear me?
Yeah, there's an echo. Is your phone on mute?
Yes.
Okay, mine too.
Or
How's the sound
maybe-
for you guys?
Maybe you have to have earphones, actually.
Is that any better?
Hello?
Better.
Okay. All right. It seems like that we are live on all the other platforms. Do you hear me? Yeah. Where is this? Oh, I heard an echo, yeah.
So I've got to stay on mute on
Now, yes. Stay on mute on the
Instagram.
Right. Let's discuss patient adherence to exercise and how to manage expectations. I should be doing this a bit. So yeah, my name is Niels Oudhuis, creator of Trust Me, I'm a Physiotherapist.
Oh, they're saying that they can't hear both of us on Instagram.
Oh. It's
because I'm on mute. It's my so they can't hear me. Return. So you should be able to hear me now.
And now I hear an echo indeed, yeah. Yeah, otherwise we have to go, everybody has to go to Facebook, Trust Me, I'm a Physiotherapist Facebook page or YouTube. And then we go live there.
Or I could put headphones in for my phone. Try that.
Could also be, but the people also don't hear me, right? I think.
Yeah.
People can hear you now. Do you hear me? Can people hear me? Yeah, that doesn't work in on Instagram. Right. On LinkedIn, people can hear me. But that's via the laptop. On Instagram, can you hear me? I think they can.
They probably can't hear me because mine is on mute.
Well, let's see. Let's just start, and otherwise they have to go to YouTube or Facebook. All right, my name is Niels Oudhuis, created Trust Me, I'm a Physiotherapist, and Trust Me Ed, which is an educational platform for physios, and osteos, and chiros, and massage therapists, and personal trainers. Everybody's welcome, with a focus on musculoskeletal physiotherapy. Yeah, today we're going to talk about how to have people do their exercises better and how to manage expectations. And I'm from Holland, Amsterdam, and this live stream is about having an open discussion with very practical tips. And we live now in a very polarizing world, of course, with heated debates on social media. Everything is black and white, just like my hoodie. But it is normally it's not so black and white. It's more gray. There are a lot of different components with everything. So it's always great to discuss this and think critically for yourself. And yeah, we try to be very practical with this. And I work as a physio for a few hours per week in Amsterdam as a manual therapist. So I also do manipulations and massage, but also focus or to combine it with education, advice, and exercise. All right. Let's invite Joanne for an introduction.
Hi everybody, my name's Joanna and I'm a specialist MSK physio working within Wales. So I work within the public sector and my repertoire of certification is that I am your typical normal MSK physio. I also specialise in joint injections and I'm also a MSK sonographer. I'm currently undergoing a advanced clinical practice masters. So I've got a repertoire of lots of different experiences. Just as Niels has said, the treatment and the profession in general isn't black and white. It's just full of colour. It's spectrum, and it's making sure that the patient understands it is a spectrum, and you treat the patient for who they are. So you kind of really ensure that you understand what they bring to the session, what they want from the session. And I think that's what today's kind of conversations around really is, making sure that we as physiotherapists understand the individual that's sat in front of us, not from a patient perspective, but also from how it fits within their life as well. So yeah, that's a little bit about me. I'm super excited about the podcast. Hopefully we can open some different thoughts and different conversations in regards to the topic today. We're not going to assume that some things are right and wrong. Again, it's spectrum, and it's making sure that how you clinically reason something is within the context, and it's married to the context at which you're kind of addressing it in, essentially.
That's very true. Always see the individual, and that's why clinical reasoning is so important, that you can see, okay, with this person I will do this, and with this person I will do this because of this. And you have to have arguments, of course, for this.
Definitely. And I think that's very much when you first start as a novice, you do need to establish your boundaries, don't you? So pathology recognition and pattern recognition is very important. You need to be able to see the triggers as to why I think it's a certain condition. So when you first start off in the profession, it's very normal to kind of float around pattern recognition and think that, oh, this is the back pain. I've got an allotment of exercises to treat every person with back pain equally the same, because you need to start somewhere. Mm-hmm. But once you get that experience, that's where I call it the spice of your treatment prescription comes in. You start to understand the person and not just the condition. You understand the person with the condition. So then you start to really amend the exercise prescription to suit the person. But we all start very much from a novice perspective of, we need to just get the experience initially and see lots and lots of different individuals. If we're speaking about back pain, lots of individuals with a different variety of back pain. And it's only when we start to see the different varieties can we really tweak our patient prescription.
That's very interesting, yeah, because a lot of on social media you hear, of course, a lot individualized approach, and if newly grads are trying to do that, it's very very difficult, because already for us with more experience it's very challenging, I would say, because you have to adapt your communication, you have to adapt your exercises, you have to think on the spot a lot. But if you are just a newly grad, yeah, you don't know, or you don't have these skills so much. You're already anxious, maybe you're with a new person. How do I do this? Do I feel like an expert? Because they want you to be an expert, of course. And then have a set protocol almost, what you always do. So you gain some kind of pattern recognition indeed. And then you can see, oh, okay, this deviates a little bit from the pattern, what I've seen. Okay, let's do this a little bit different. Or, okay, I have to think a bit more about this.
And it's usually when you've given that standard allotment of exercises and you've kind of seen the patient for 6 weeks and you're not seeing significant differences, then you're starting to step back as a clinician and reflect and think, hang on, this allotment of exercises doesn't work for everybody. So, right, I need to now actively think, I've got the the pattern recognition here, but I also need to be able to use my own kind of evolvement of clinical reasoning as to how I change this protocol. And that's when you start to build in your own kind of professional development and move away from pattern recognition. So you have to always see that patient full circle for you to kind of realize, it doesn't work for everybody.
And do you have some tips on how to be better with clinical reasoning? How is your process of clinical reasoning?
So with my clinical reasoning, I'm very much a patient-centered physiotherapist. So I take a good subjective history typically, and I kind of typically work out what is truly important and what's priority for that patient in that moment. Because if it's not priority for that patient in that moment, it's very difficult to manage expectations. In that, if an individual has a lot of could be personal circumstances that are more biased towards psychological strain, then I typically say that maybe your physical may not be the biggest fish to catch at the moment. It's little fish in a pond, but it's still vital. It's still a very pivotal segment in your whole well-being. But I understand that you may not then have the time to dedicate to doing all your exercises. So in that instance, then I will, depending on what condition they come through with, I will then educate in that manner, but I will also just give bare minimum exercises. So maybe 2 or 3 exercises, just so then they can do daily or every other day. I just want them to start exercising in some manner, just so then they can kind of break out of the mindset that I cannot do. I don't mind what it looks like. It could even be just walking for 20 minutes. I don't mind that. Anything where the exercise does not produce lots of psychological barriers, I'm happy with in that first instance, just to tip you over that initial threshold, to just buy you that ability to trust me, build that rapport and trust me that if you do a little bit of exercise, you'll start to feel better. And it's only when that patient starts to recognize those benefits, can you then start to become a bit more specific generally? And that's talking in general population. I think when we start to then isolate into athletic populations and young adults, it's slightly different. You have to pitch it slightly differently. So then I guess my reasoning in those instances, and this might be a blanketed stereotype, but athletes are usually very regimented. They like direct and informed kind of nice prescriptive exercises. And they like lots of exercises as well. And they typically will follow it to the T. In those instances, and I worry about, right, this individual might be overtraining. So do I try and not necessarily underprescribe, but start a little bit softer and kind of do a soft prescription and see how they respond to those soft prescriptions then?
And also explain it in that way then, that it is important to just rest a little bit or to reduce the load.
Exactly. I typically will advocate intuitive practice. So I want the individual to take advocate of their own rehab, essentially. So they need to be able to, right, I've encountered a pain. Is that a soft resistance or is it a hard resistance? If it's a soft resistance and it changes when I readjust my form or I change something, then I typically will say that's a soft resistance. So like a stretch. A stretch, you can't say that you can stretch without pain because everyone's description of pain is very different. It's very subjective. So one individual's initial bind to a stretch may be painful. Another will realize that that is a stretch sensation. So then, okay, I usually say hit that first bind and see whether that sensation starts to change. If it starts to change and invite you into more of a deeper stretch, then that's a soft resistance. If you've held it there for a little while and it hasn't changed at all, I'm starting to believe that maybe a hard resistance. We need to move away, have a little reset, and try again. If you meet that same hard resistance, we stop on that day, because we need to then factor in on that day that individual may not have rested properly, may have had a bad night's sleep, may have overtrained the day before. Lots of different components can then cause differences in symptoms.
And then the brain is really like focused on protecting the area. Then that's what you mean, right?
Protecting, and also to not, I want the individual, especially athletes, to not follow the prescription to the T despite how it feels for their body. Because they'll say no pain, no gain, which is a very common phrase.
That's a good one.
Yeah, sometimes isn't the case. Sometimes pain is there as an adaptive response and not a maladaptive response. So it's then for the individual to intuitively realize the difference and to empower the individual to realize the difference.
Yeah, indeed. Yeah, that's a good one. Yeah, that you have like a soft and hard resistance. That's a good one. Because then, you have, if somebody sees or feels better themselves what they can do and what they cannot do, that gives them empowerment for sure. Yeah, that's a good one. Somebody, Josh Devine, said on Facebook, I think it's also important not to just rely on pattern recognition and be aware of your own biases. As a novice, we often use a lot of type 1 thinking, but as you develop, you use more type 2 thinking. But even that has errors. It is important to be open to each individual. Yeah, that's of course true. Do you want to say something about it?
Yeah, so just exactly that. Patient-centered treatment is what we typically evolve our treatment pattern around, really. Pattern recognition is usually seen more commonly in those that have just qualified, because you're trying to get some credence, you're trying to get a foundation, you're building a foundation first to be able to then develop. And it's only once you've got that foundation and you've seen enough people come through your practice, your clinic, your practice, wherever you may be, that you'll start to evolve in your thinking. You'll start to realize, okay, I can start to change a little bit, because now I'm comfortable that I've got a foundation, that I've seen enough people to then decide, well, this protocol is not efficient and effective for every individual. But yeah, it's so important. Patient-centered care it's paramount. But when you first qualify, it's sometimes very difficult to ensure that you've got all your anatomy on point, all your different treatment modalities available, and applying those treatment modalities properly as well, ensuring that clinically reasoning that you're able to apply the treatment modalities safely for that individual, and then take into consideration the individual's circumstances as well. It's a lot for a learner.
And then also be able to think on the spot with somebody looking at you, thinking that you have to be the expert. So you have to be very quick to say, and also be confident in how you say stuff. Yeah. Plus you have to be able to have a conversation with that person all in one go. Yeah. So that is for sure. Of course. And some people, I think, have a better like internships or maybe mentors on in the clinic. Some people don't have that so much. Yeah, and they have a hard time for sure. I hear it a lot.
And some individuals, some therapists are natural communicators, whereas others are more profound in theoretical knowledge, so that's different as well. And I think we've seen a lot of infographics lately that have been floating around on the internet stating that a physiotherapist, when we start to kind of categorize an effective physiotherapist, communication is paramount. It's so important. And that's not just communication through verbal, that's comprehension as well, understanding what's coming back to you and understanding that in the context of that individual, and not having your biases, meaning that, I don't know, some individuals in clinic may think that osteoarthritis in the knee, once it gets to moderate to severe, there's not much that physiotherapy can do from that perspective. So then they don't necessarily take them through the rehab program. And that's a strong bias, whereas some individuals, some professionals will say, or what's the worst that can happen? If we do some exercises, let's call it prehab.
Yeah.
It'll put you in good stead for if you do undergo arthroplasty.
For sure. I had a question, but I forgot about it. How do you normally say practically to your patients, okay, we have to do these exercises, they will be good for you. And how do you get them to adhere also to the exercises? Because yeah, a lot of people are giving the exercise and they don't do it because maybe they don't feel like it. They don't have the habit yet. They don't think like this is important for me because or the person hasn't listened to me really what my real problems are and just give me some exercises. What do you think?
So my assessment and my production of how I deliver those exercises start from the subjective. So as soon as I start to take this subjective, I start to understand the individual and what sort of experiences they've had previously, be it with physio, chiropractors, osteopath, whoever it may be. If they've said to me, I've seen 4 physios before and I've not had good success from it, I want to understand why. I want to, what did they prescribe you? And was it well explained? Do you know why those prescriptions were put in place? So I want to kind of establish as to why maybe things have broken down previously. So whatever condition they present with then, I will typically try and through every step, educate and give them from a guidance perspective, from a professional guidance perspective, how all physios are governed in treating this condition. So it'll be usually conservative means first, and if conservative fail, then you start to go for more invasive means. So for example, for a back, most individuals, not most, that's blanketed, that's a blanketed statement, but some individuals will come in and say they want an MRI because they want to know. They just want to know what's going on. But I will then say to them, in the UK anyway, there is typically a criteria as to why we would send for an MRI. And usually it's for more kind of radiculopathy type presentations or red flags or anything that you have true concerns or complex presentations in regards to. And if we're sending you for an MRI, we're typically worried and concerned that something's going on that you may need more invasive forms of treatment. So be it that the MRI is going to inform whether you need a spinal injection or whether it's that you may need surgery, but you probably are going down the route of orthopedic opinion. If you don't want to go down that route and you are in absence of any of the cardinal signs of why we would send you for an MRI, your treatment plan doesn't change. We're going to treat you conservatively anyway. So if my suggestion would be to try the exercises and see how you go, I will typically prescribe the exercises and also manage expectations and say that this is a trial and error. Typically, when we prescribe exercises, it is always trial and error. You have to see whether the body responds to it and that individual responds to it as well. But I also will put a time frame, a rough time frame as to how long they need to be consistent with these exercises before they start to notice a change, not a full recovery, a change. And then it's typically then within 12 weeks, if your radiculopathy hasn't improved, we then start to think, right, okay, do we need to start thinking about more diagnostic scanning? But that first 12-week period is typically what we're going to use to throw our best efforts into conservative. Because given an individual, you probably are not going to want to jump straight onto surgery if you haven't tried everything else before.
Sometimes the surgery immediately is, of course, necessary with cauda equina syndrome, but not for the radiculopathy, of course. But yeah, time is also an important one. Just let the body heal and then give some stimulus indeed for like exercises, movement, and then the body can heal better maybe.
There's also been instances where I think we're in such a paradox at the moment. We're in a transition phase. So we've kind of started to move from very hands-on manual therapy touch physio to
Mhm.
now more education physio to empower the patient. And I think there's a generation of patients that are stuck in between. Well, 10 years ago, I had a lot of massage, a lot of manipulation, a lot of hands-on. And now 10 years later, things have changed so drastically. You barely want to touch me. Why? That's a rubbish physio.
Mhm.
So we're in such a transitional phase of the profession. I think it's very tough for physios at the moment, especially who've been in practice for a little while, that have seen that shift, to try and shift the cultural mind of the patient that's sat in front of you. So you probably will need to do a little bit of hands-on, give them the education as to why hands-on is great as an adjunct, but not as an independent intervention. And hopefully, as the years kind of progress, they'll start to understand, okay, hands-on may not be the most important and paramount part of my rehab.
Mhm.
I'm the most paramount. My consistency and resilience in doing the exercises gives me the longevity. But you might, to open a window, you might need to start with a little bit of hands-on.
Indeed, yeah, to get the trust of the patient, to know also, the patient sees, okay, the physical therapist knows what I want and also does that, and then slowly you can bring the patient towards what you want. Indeed, yeah, to be more like a guide or a coach, and to like a life coach almost, to see how you can cope with stuff better, to how you deal with things better in your life, with stresses, and how you, yeah, all these things. And how do you build resiliency in patients? Do you have some ideas about that?
No, I usually just trust that the individual, I guess resilience sometimes initially is debatable in a patient, because they have to trust that the exercises work. So they're in that phase of, oh, I don't know if this exercise is going to work. You have to say, with consistency, only kind of 4 to 6 weeks down the line are you going to start to notice a difference. So I guess the verbal motivation there has to be quite strong from the physiotherapist. It's almost like you push them, and they get to an epiphany to the point where they're like, oh, if, for example, to quantify, I had 5 bad days a week, now I've got 2 bad days a week or 3 bad days a week, then they start to notice a difference. That self-motivates them. It's in those instances where they start to realize, oh, it's starting to pay off. I'm going to carry on with the exercises. But initially, I do find it hard to kind of engage the patient to keep with their exercises. If you have the resources, it's maybe worthwhile seeing them on a weekly basis. So then you have got a routine touch base. So then they feel it's not the best way, but sometimes patients will feel, I want to do good for my physio because I'm getting checked up on in a week. So I'm going to do it because someone's kind of watching me. So they almost externalize their reasons for doing it. But once they hit that point where they see recovery or they see an improvement, they start to take some of that ownership. And I also give them that ownership. And I said, look, I know
it's on you.
Yes, this is all you. I'm just the coach, exactly what you said. I'm here to coach you. I'm not here to fix you. You fixed yourself. So it's ensuring that you empower that patient as best as possible. So then they don't then, 10 years down the line, if they have a recurrence of the same condition, come to a physio and hope that physio will fix them.
Yeah, it is also like if you have a car and it's broken, you go to a car shop or whatever, garage, and to let it fix. And if you have a heart problem, you go to a doctor to fix it. And then with the physio, we cannot do it so well, or we are not so good with this. Of course, we don't have a real fix tool to be able to really fix stuff. So that is difficult to also sell, because normally if you have a problem, somebody fixes it and that's it. And then you pay something and that's it. We have a more difficult situation, I would say, to be able to sell our worth almost in the treatment.
You sell uncertainty. If you are a good communicator, you can sell uncertainty, because you need to keep them blinded to the point where they start to see it themselves. It's really strange because they won't see it, because we as physios have seen so many patients with a similar condition come through our clinics. We know that full cycle and full circle. There are obviously anomalies. There are some individuals we can't fix, but generally for a condition, you'll start to see that, oh, well, they'll get to a certain point, say 6 to 8 weeks, roughly. They'll start to notice a difference. So you try and get your patient just to get there in the first instance. And if they're gonna start to notice a difference, they start to take ownership.
And they have more trust and confidence in themselves and in you.
In the exercises and the prescription.
And in the process, yeah. The process of getting better and getting a better life without or with less pain or without pain. That's of course what they want. So they can do the things that they want.
Okay. And that builds more longer term resilience for that individual.
Yeah, if you do stuff repeatedly, every time little steps, and if you're confident, if you win all these things, then you bring in confidence for yourself, or you become more confident, and you become more resilient also then.
And there's a part in that the repetitiveness of whatever you were doing starts to build a habit. We start to kind of get into neurochemicals then. We start to think of like neuroplasticity and starting to pave ways in the cortex where you don't have to think about what you're doing. It's a non-negotiable. You just do it instinctively. And that's what I typically try. If the patient has the ability to understand that, I do try and form that as part of my education, because it doesn't come out of the air spontaneously. You have to keep working at it for that neuroplasticity to change.
Yeah, also with exercises. If you don't check the exercises for the patient, then the patient is not doing it for you, only for them, and then probably they don't do it. Exactly.
Patient advocacy and self-advocacy is generally, from my experience anyway, typically it's a little bit lower in the first instance, because they feel like they're working so hard in the first 2 weeks and they don't notice the difference. And when they come back and see me, they say, I don't notice the difference. I say, aha, that's the perfect response, because I wouldn't expect you to notice the difference. Keep persevering. And it's okay to say that it's in those moments, if you're not intending to notice the difference, tell them.
Indeed, manage expectations from the beginning already, because then if you say it will be better in 2 weeks, but actually normally like physiological healing is taking 8 weeks, yeah, then they will get disappointed, of course.
But when you're a novice, I remember when I first started, I was almost disappointed, because I'm a bit of a perfectionist as well at heart. And I remember seeing patients back then, we weren't so saturated, so we were able to see patients on a week-to-week basis, or maybe every 2 weeks. And you'll go, how are you? How are things? And I go, no different. Yeah, and there's a part of you that just sinks, and you think, well, why? Do I need to change my exercise prescription? Or is something not quite aligned to what needs to be in your rehab program? But now I have the confidence, after years and years of seeing that full cycle of patients going through my clinic, my treatment room, that I'll go, yeah, that's fine. That's what I expect. Give it another 4 weeks, same tenacity, bring the same kind of energy to your exercises, and let's see.
And of course, you have to know all your physiological healing processes, like tennis elbow will take this long, frozen shoulder this long, and you have to an acute ankle sprain. And if you know that, and if it doesn't go well like you expected, then you have to change. Okay, what's going on here? Maybe we have to see how you cope, maybe, or maybe there are some other things, stresses, or how you deal with it. I think that's very important to check them with patients, yeah. And then communication comes in, which is very important, to be able to listen, to be able to express your explanations very well and adapt it to the patient itself. Because if you have a lawyer as a patient, you have to use a little bit different words than with a bricklayer or something like this. it's always in the culturally differences. You have to adapt your communication a bit, yeah.
And I think it's also really important that all physios need to understand that it's okay to not know as well.
Yeah.
And it's okay to not be able to fix someone. So to know your limitations. I think that's
But then the patient says, yeah, well, I come to you, you're the expert, because I don't know, I have pain here.
But you have to be honest. If you don't know, you can't just magically offer something. In that instance, it's signposting. Here, we do a lot of signposting. So if it's not within our remit or it falls out of our remit and we're not the best person to advise, we would then signpost either back to the GP or to the next, whoever the best specialist would be. It's knowing your limitations as a physiotherapist, and don't feel like you are GP, orthopedics, physiotherapist, all of that, you know, it's okay not to know.
But it's easy if your agenda is super full and you have a waiting list. But if you need some more patients, then it is a challenge to keep patients also.
But then I think you build respect in an individual. If you can tell them, look, these are the reasons why I'm not sure your presentation is a little bit more complex and you've got this facet to it, this thread to it. Usually these conditions may present in this way. So I'm not quite sure. I think just to ensure that you get that well-rounded treatment and care, I'm just going to refer you on to ensure that shows safety in the professional.
Mm-hmm.
And that patient then probably would be willing, especially if it's private, to come back because they trust that you're not there just to take the money.
For sure. I see that Kinan is in the waiting room. Let's bring Kinan in to see what he wants to bring in. That's a nice thing of the live streams. We can bring people in.
Are you here to tell us off?
Yeah. Let's see. Connecting the audio. Let's see if it works.
He's in. Have any of our viewers or listeners got any questions? I'm more than happy to answer questions.
Yes, Mihai said you need to take into consideration the level of education they have, and you have to speak on their language. That's what I was also talking about. And make them understand the condition they have and present the solution they have. I find this works very well.
Yeah, physios use a lot of analogies and metaphors.
Mm-hmm.
I find that, yeah.
Which metaphor do you use the most?
Any metaphor or any analogy that will work, that will drive that point home. I will just magically pluck things out of the air. I think Kenan's stuck.
Yeah, it doesn't work now. No, I like the bucket metaphor a lot. Like if you have pain, the bucket is overflowing, and the bucket sometimes it's already like half full because you have some underlying condition, some stress at work or something, and then every time you didn't sleep well, you feel run down because of sickness, whatever, then your bucket slowly fills up, and then Keenan went away, and then it slowly builds up, and then then it overflows, and then you put your sound off.
My dog is barking in the background.
And then you feel pain. That's what it means with the overflowing. Yeah. And if it's overflowing, you have to see all the factors that is making the bucket full, and then you try to identify the most important ones, and then work on this. And most of the time, that works pretty well.
I use the bucket quite a lot as well. Generally more for kind of a representation of energy. So I'll use your bucket only holds a certain amount of energy, a finite amount of energy. If your energy is being used for psychological stress or whatever else it may be, it could be work stress, psychological stress, personal stress, whatever, you've only got so much to then put into, as I mentioned earlier, into your physical.
Mm-hmm.
So then you need to start establishing what is priority, what's most important. at this present moment in time, what is most important? So that I use the bucket quite a bit. I'm trying
Yeah,
to
we have a saying in Holland, it's difficult to translate, but when you have stress, it doesn't go into your cold clothes. That's how we say it in koude kleren. It doesn't go into your cold clothes, it goes somewhere. So in your body, it doesn't go to your big toe, it's going to your neck or your spine most of the time. The stress goes to your neck and to your trapezius and stuff, and then also to your low back when you have some worries or anxiety about stuff, which I have done sometimes. I feel it immediately. Okay, this is because I worry about this. And it's not about my discus or my vertebrae out of place. Well, maybe, I don't know. I cannot see there. But I just say to myself, okay, this is the stress and the worry I have. Just relax a bit. Breathe deeply and keep moving. And sometimes rest a little bit on just laying on the bed is also fine. And then it goes away within like a week or two or something, or a few days even.
stress is not only physical stress. There's a really good book called The Body Holds the Score. It's quite a difficult one to read because you really need to be switched on. It's not a fictional book. You really have to be engaged with the topics and the themes. And essentially it kind of starts to really put into place as to why some individuals won't feel pain or won't feel stress, but their body shows all the signs of stress. But psychologically, they're so good at blocking out stress and any emotion because of the harm, the psychological harm, whatever harm they've been kind of been placed under previously. They're able to block the conscious ability to understand that they're under stress. And I think you see probably quite a lot of these patients that come through our doors. And
our doors? Oh, our doors.
Yeah. Treatment rooms, yeah. So these individuals won't realize that their shoulders are up here and their upper traps are really tight and they've got gastro issues and they've got lots of other kind of inflammatory issues, generally kind of unwell, but not ticking any red flag signs. And then you think, well, what are your stress levels like on a day-to-day basis? We'll go, I'm all right. But they're probably chronically stressed because they've been at this chronic stage for such a long time. They can't then start to understand, well, that's their new norm. They don't know what normal kind of emotive levels should be. And there's no normal, but I guess your normal is when your body starts to dysregulate and when you tip over. That's when your body starts to dysregulate. So yeah, it's a really good book. Really, really kind of highly recommend it.
And the title was The Body Keeps Score?
The Body Holds the Score.
Holds the score, yeah. Yeah, that's very important. I think a lot of people are avoiding indeed these problems in their life, stress, and not confronting them. I think that is the biggest problem, or at least that's what I think. Because if you confront them, which is more difficult, of course, because in the short term it's more difficult and more challenging. But eventually you become more peaceful and more at ease with yourself. Also, you have less worry. At least that's what I have seen within myself. If you avoid it, it will always come back. So, and it always come back in different ways. Maybe indeed in your body that you have intestinal problems, the stress goes there then, or in your neck indeed, chronic neck pain, chronic back pain. I think avoiding of fears, also in general, actually, avoiding of fears and avoiding of worries and stresses. That's a big thing for all human beings, actually.
Definitely. And that's where well-being. As physiotherapists, I know in our title it says we need to focus on the physical. I typically will always kind of touch a little bit on the emotional as well, because you have to treat the well-being of that individual. You can't just treat one facet, because how intertwined they are, it's unmeasurable. You can't even describe how, and I think it's only now research is starting to found the tight interconnection of the both. So yeah, I in my opinion, a true effective physiotherapist will treat both.
For sure. But yeah, we never learn these things.
You have to go by intuition. This is, again, your full cycle of seeing lots and lots of people and starting to develop an understanding of, the presentation is very similar to all the lower back pains that I've seen previously from an objective measure, but it's not responding the same. But there are no other hints that this individual needs any further MRI, diagnostic scan, that sort of thing. What's going on? Mm-hmm. So then you start to research and read up what other profound factors could be involved here. And I think Pete O'Sullivan's a really good physiotherapist that kind of addresses this.
For sure, Peter O'Sullivan is awesome, and his CFT course is great to see. That when he treats people live that he didn't see yet, and who has 20 years of chronic back pain, who didn't bend down for like 10 years or something, and then within that session they are bending down. And it's also about confronting their fears, of course. They are fearful of bending because they have hurt their back 10, 20 years ago with bending. So they think, okay, I shouldn't be doing this because then my disc pops out, whatever they have their beliefs are. And then the main thing he will do is focus on the most fearful movement and pound on it really. And like the whole, all the physios who are watching, like, that he's just pushing them into the pain again. And we would just stop that. Okay, sorry, we don't want to give you more pain. He just keeps going. And then also with more body awareness, breathe. Are you holding? Practice. Are you creating tension? Breathe and relax, and then you can move better most of the time with bending. And that's beautiful to see. He is very skillful and a great clinician. But for the young physios, that's a big challenge. I've tried it many times. It didn't work a lot of times also.
But this is the thing. It's very much about the education in the first instance, but then empowering the patient to decide as to whether they bend forward a little bit more, to what degree, to what angle, right? What are you feeling there? Truly in that moment, what are you feeling? Is it more of a psychological fear, or is there true pain there? Are your nociceptors popping off at this point? And you have to empower that patient to decide whether they bend or not. And that's where I am in my practice. And Pete O'Sullivan's got years on me, likely. So he's seen more and more of these patients go through his treatment room. But you start to build that confidence. You do. There are certain signs that you start to see in your treatment room that will tell you this individual can be pushed a little bit more safely, but with the consent of that individual.
Of course.
With the hand-holding of that individual. That essentially, that individual, that patient leads you and guides you. Because if there's a lot of psychological burden there, you don't just go, look, all that psychological burden, you've manifested that. I don't believe in any of that. Just bend. Because they're instinctively, emotively will go, no, you don't know what you're saying. You don't understand my pain. I've had this for 10 years. I've lived in this body. I know better than anyone else. And that's true. They do know their body better than anyone else. So you have to understand where they're at in regards to that.
You have to show that you are confident, of course, that you show that you're empathetic, that you have listened a lot. That's what he does, of course, also in the beginning. A lot, the whole story comes out. It shows that you are interested in that person and that you want to help. That's very important, yeah. Because if you are indeed very harsh, like just bend, the science says this, okay, let's just do this. Yeah, that people become more defensive then, because it also shows that you are not really listening to them and not really caring about them really. So that's a big thing for sure. Exactly. But all right, let's wrap it up. We have been having a great conversation already. Let's end with some maybe some practical tips, practical tips about how to, or maybe like a little summary about how to have people better adhere to their exercises and how to manage expectations.
adherence, I think the key factors here is communication, education, providing a realistic time frame for the pathology as well. And I think that will feed into the second part of that question, really. You're in those elements, you're managing expectations already. The adherence is tough. The adherence initially from the physio, I think you have to try and push a little bit harder initially, but that individual will get to a point where they'll start to self-advocate when they start to see the benefits of the exercise. And that's probably more of an anecdotal experience, but that would be my suggestion, my key tips.
Sounds very good. Thank you, Joanna, for this great conversation, and thanks everybody for watching and for the questions and for listening. We will try to fix the Instagram live stream, but that will be fine next time. All right. Thanks, everybody. Thanks, Joanna.
Thanks, everyone. Bye.
Bye-bye.
Bye.